Good afternoon, I'm Dr. Lang. I'm a third-year psychiatry resident. I'm presenting today, bridging the gap between CL psychiatry and trauma surgery in a Mexican-American patient with a complicated brief psychotic episode. So a little bit of background about this case report. I wanted to highlight healthcare system level issues that are prevalent and create disparities between surgeons, hospitalists, and psychiatrists when they communicate. These issues affect minorities and impoverished individuals at a disproportionate rate. And in this case report, in this patient who presented with a complicated surgical and psychiatric hospital course, there were social inequities that served as barriers to acquiring and utilizing mental health services. So briefly, this is Mr. G. He's a 41-year-old Spanish and limited English-speaking Mexican-American male with no past psychiatric history who presented to the ED after he was found in a bathtub extracting his teeth, attempting to screw a large threaded bolt into his mandible and inflicting lacerations to his face. Pertinent background, he was recently diagnosed with COVID-19 pneumonia. This was before the vaccine came out. He required hospitalization with oxygen and glucocorticoids. His condition improved and he was discharged home, but then he experienced significant stressors thereafter. Specifically, his wife was hospitalized with COVID, requiring intubation. She did, of note, ultimately survive. During this collateral information, in the midst of these stressors, Mr. G developed psychotic and manic symptoms, including not sleeping for 3 days, talking to Jesus, and engaging in the injurious behavior as above, necessitating his rehospitalization. His GCS score was 6 on arrival to the trauma bay, and he was intubated. UDS was positive for benzos. So here's some relative imaging supporting the HPI. This is a CT max face without contrast, an initial presentation showing his right mandible has multiple fractures, he's missing multiple teeth, and he has extensive right facial soft tissue swelling. So the overview of hospital course is lengthy, but I think it's important to help kind of clarify some of the topics of this case report. So on the 19th of January, Mr. G underwent surgery to remove the foreign body, as well as closure of his full thickness lacerations, an ORIF of his right mandibular fracture. Following his initial treatment, the trauma team started him on risperidone, 1 milligram daily, while the patient was still intubated. The next day, he was noted to have new onset right upper extremity weakness and these kind of rhythmic movements of his torso, which were not present on arrival. 2 additional days later, psychiatry was consulted for the first time. We gave him a diagnosis of brief psychotic disorder. Differential based on his HPI included steroid-induced psychosis, COVID psychosis, and autoimmune and infectious sources of encephalitis. Our mental status exam was limited because the patient was intubated. However, he was no longer agitated and not appeared to be responding to internal stimuli. This was the first time that any collateral information was obtained from his family during the hospitalization. So prior to this, we did not know anything about how he got into the hospital. At this time, we recommended continuing risperidone. So psychiatry kept Mr. G on their consult list, however, kind of followed peripherally some of the broad brushstrokes of his hospitalization. So he was admitted on the 19th. This is on February 3rd. He had a tracheostomy placed as he was on the ventilator for 3 weeks. And then almost 2 weeks later, on the 16th of February, neurology was finally consulted, where they noted his LP was negative for autoimmune, paraneoplastic, and viral encephalitis panels. And then kind of other summary, he was in the SICU for over 60 days total, requiring multiple procedures, including a tracheostomy, a GJ tube, replacing his tracheostomy. And during his hospitalization, he physically deteriorated and developed quadriplegia of unknown etiology despite labs and imaging unremarkable. So on March 3rd, psychiatry reevaluated Mr. G. His mental status exam was most notable for severe dysphoria, but features of psychosis remained absent. Of note, he was still difficult to do a full mental status exam because of his tracheostomy and limited understanding of English, but he was kind of able to nod yes or no to simple questions. The team decided to start Mr. G on escitalopram 10 milligrams daily, and trazodone 50 milligrams at night. At this point, risperidone had remained on his medication list since it was started in the beginning of his hospitalization, and at this point, psychiatry now recommended discontinuing this medication. Again, psychiatry kept this patient peripherally on their consult list. And then on March 30th, Mr. G was finally discharged to an inpatient rehabilitation center. He was not reevaluated by psychiatry prior to his discharge, and subsequently was not given outpatient psychiatry follow-up at the time of discharge. So that concludes the hospital course of this case report. So going into the discussion, studies demonstrate that patients with limited English proficiency are less likely to receive continuity of psychiatric services compared to English-speaking patients. It is imperative to fully recognize this and address this inequity, as the consequences of such were evident throughout Mr. G's hospital course. Further points of discussion for this course is notable to talk about that Mr. G was on a subtherapeutic dose of risperidone for his initial symptoms of psychosis. This was started by the trauma team before psychiatry was able to do an exam of the patient, and he remained on this medication for over a month in the absence of ongoing psychotic symptoms. Also, his depressive symptoms weren't recognized or treated until late in his hospitalization, likely as a result of communication barriers. Similarly, there was a delay in obtaining collateral information necessary for diagnostic clarification. Also, given the length of hospitalization, communication between primary team, the trauma team, and psychiatry CL service was relatively infrequent, and I do believe that this resulted in suboptimal discharge planning in terms of psychiatric follow-up. In addition to the sociocultural influences, this case report is noticeable for kind of having a complex differential diagnosis at the time when neuropsychiatric manifestations of COVID infections were poorly understood. He was given a diagnosis of brief psychotic disorder, and his presentation was unusual given his quadriplegia and negative neurology workup. So his autoimmune infectious causes of encephalitis were negative, but it also is important to note that collaboration with neurology was also delayed. As this case highlights, as we continue the discussion, bridging the gap in healthcare inequities does require the development of a more collaborative network to ensure that minority patients and those with limited English proficiency do receive necessary consultations and follow-up in a timely manner, as well as coordination of care upon discharge for appropriate outpatient services. And these are my resources, and thank you so much. I look forward to participating in the discussion. Thank you.